Okay, good afternoon, everyone. My name is Sarah Van Wagenen here with the Mortgage Collaborative. We're right at 2 p.m. Eastern, and I want to thank everyone for joining today's TMC Connect webinar, Rethinking Healthcare, How a TMC Member Discovered a $130 million Producer, hosted by our partners at Cairn Advisors. So for today's call, just so you guys know, all lines have been muted just to avoid any background noise. And definitely feel free to submit any questions you have throughout the discussion, and I can verbalize them on your behalf. Our discussion leaders today, we have Taylor Rogers and Rich Haney with Cairn Advisors and Michael Jones with Thrive Mortgage. So without further ado, I'll let you guys kick things off.
Perfect. Well, I'll start us off here. So appreciate everyone joining us today. And it was great to see many of you out in California for TMC's reunion conference. That was amazing. Great to see everyone. And some of this is content that we covered there, but there was a fair amount of interest and other things that we wanted to make sure we covered. And so thank you to TMC for hosting this. But there's two reasons why I'm on the call. So the first one is that through our pain, we at Thrive Mortgage discovered a much better way to deliver healthcare benefits to our employees, as well as lower the cost of those benefits, which result in multi-million-dollar level of producers. So that's really where this tagline comes from, and we'll show you guys how that number can be justified and how you could arrive at it as well. But the other reason why is partners here with Rich and Taylor in this endeavor to really teach mortgage companies specifically, and then others outside the industry, how they can take charge of their healthcare spend and avoid all the games. So with that, I'll hand it over to Taylor Rogers and introduce yourself, I guess.
Very good. Yeah. Taylor Rogers. I am working alongside, obviously, Thrive Mortgage and one of the co-founders of Cairn Advisors. And so been in this business for a number of years and have seen many of the games firsthand that Michael alluded to, and what we effectively equate to an arbitrage opportunity for employers who take the time to understand, or at least hire wise counsel to understand and fix the ills of the system that have cost them a lot of money over the years. Rich?
Yeah, my name's Rich Haney. I'm one of the partners here at Cairn as well, and spent several years on the administrator side, working for both a large national carrier and a third-party administrator where we help companies go self-funded, and really excited about this opportunity because we think a lot of people don't understand what's happening, and there's a lot of misinformation out there, and you just sometimes just give in to what you're told and think that there's no other way outside of just buying health insurance on a spreadsheet. We're effectively reducing it to one number. And I think we've shown with the success with Thrive that you can actually make a really meaningful impact for your employees by just taking a couple, what do we like to say? It's taking it from, one or two big decisions per year and breaking it down to 5 or 6 throughout the year and just actively managing the risk.
Yeah. So I think we're going to start off. I think it's important to understand what the actual problems are. You don't have to know everything about health insurance, but to understand why healthcare is expensive, I think informs the solutions. We're going to go into how you overpay for claims today if you were to go through your own data. And then we're going to move into an overview of underwriting. This is a fundamental for folks to understand. Anybody who's purchasing benefits for a company, you need to understand the jargon and the terms and the acronyms that they're throwing at you in these discussions. So we want to inform that very, very quickly. And then some steps you can take and some practical questions that you can ask to start moving the needle wherever you are today.
And then the last thing is if you'd like to learn more, we're an open book. We just want people to understand what's going on and how they can become better purchasers of healthcare.
All right, so I want to let Michael kind of run with this because this equates some of the success you can have back to mortgage and Backwood. You guys obviously is near and dear to your heart. So go for it, Michael.
Yeah, absolutely. So, the 30,000 foot view level is I took over our health insurance management, I guess, in 2015, just as I worked in coordination with our HR department. And just year after year after year, we kept getting hit with increase after increase after increase. And so we fast forward into 2020, and we had a $2 million benefit budget for about 194 covered lives. So we had more employees than that. I think we were a little over 300 employees at the time, about 194 covered lives. And so we were facing a 20% renewal increase. And that was par for the course for us. Some years it was 8%, some years it was 20, some years we could get a pass or go a little bit lower by jumping around. But then of course, lo and behold, it would jump right back up again. And so finally we'd had enough. And so as we looked at what this additional spend was going to cost us, it was $400,000 of additional premium. Well, for anybody that's in the mortgage business, everything gets related back to basis points. And so that $400,000 of additional premium was going to be about an $8 million producer if the corporate back end, company all in net is making about 50 basis points on its production. And so we all know how hard it can be to recruit an $80 million producer. It is not easy. And it's also not something that can be consistent. That producer may be doing a lot of refi business. They may lose their top, referral partner. And so for us to be able to try to tackle this problem, which would be 400,000 or an $80 million producer, and be able to control that cost year over year, that's meaningful to a mortgage company, particularly coming out of 2018 style margin compression. We know margins are already coming down from the highs of 2020. And so it's more important than ever that we keep control of the things that we actually can control spending on.
Yeah, no, I remember asking Michael, I said, if we could save you $1 million, which based on what they were looking at, what would that mean to you guys? And I think you'll see toward the end, we'll kind of review what Thrive's done over the last 24 months, really. And we've actually exceeded what we were hoping to do in that regard. So we'll get to that in just a moment. Rich, you want to go to the next slide? So we kind of went back to, we want to zoom out kind of to outer space so you can understand how we got here. And the Affordable Care Act, everybody's familiar with at this point, was passed back in 2010. And so we have the winners and the losers here for you. And no surprise, the winners of the Affordable Care Act are these four companies here in the white. Well, in a few more, but Humana, United, Cigna, and Anthem, if you look at their stock price growth since the passage of the Affordable Care Act, you're looking at 1,300%, 1,500% growth, almost 1,000% and 792%. Well, the cynical perspective would say the whole market has exploded since over the last 10 years. So how does that compare? If you look over here, the Dow and the S&P have gotten pretty well obliterated by our health company portfolio here. So you could have made a lot of money if you just picked any one of those and well outperformed the S&P. So they're winning. Let's talk about who maybe is not winning in that equation. And this effectively is employers and employees. So to boil this down, in the left, you have the average cost of covering a family in 2010. This is according to the Kaiser Family Foundation, right around $13,700. If you fast forward to 2020, which was this study here, you're well over $21,000 to cover that same family. And in the meantime, Rich, if you want to go to the next slide. Never mind. I guess we don't have that.
Well, no, we're gonna go dive into that. But the reason why this has happened, there's a couple different. The first thing is back in the day, I'm sure y'all remember, we used to have a lot of competition in healthcare. You could throw a rock and hit 15 different insurance carriers. And today we live by an acronym in our world called BUCA, Blue, United, Cigna, Aetna, and Humana. And that consolidation, if you look at any other industry that has had the type of consolidation that healthcare has, prices have not come down for consumers. Airline, cable, I mean, even think about cell phones. There used to be 100 different carriers back in the day. Prices have not come down to meet that consumer, regardless of what you would hear of. We're going to have more efficiencies.
Yeah. So net promoter scores go down and costs go up. And that's what we've seen in consolidation. That's exactly what we've seen in healthcare. And so a lot of that is due to this one rule. And we asked this in California when we had, folks there front and center present for this, but we asked everybody to raise their hand if they were familiar with the MLR rule. And effectively what this rule is, it was embedded in the Affordable Care Act. And it said that health insurance carriers for fully insured business had to, for every dollar they took in claims, they had to pay dollar they took in premiums, they had to pay 85 cents in claims, leaving 15% for marketing administration. And so in profit. And so when you look at that just at a business level, you go into any industry and cap a margin, the only way to keep shareholders happy, continue to grow the business, is to see the entire size of that industry increase. And so we've seen that. We went from about a $2 trillion healthcare system to now we have over a $4 trillion healthcare system in the United States. It's about almost 20% of our country's GDP. So it's a very significant, chunk of what we do as a country. And this is why, because 15% of 1 trillion is more than 15% of 500 billion. So it's pretty straightforward. We like to reference this quote often: show me the incentives, I will show you the outcome. This is the foundational principle that has caused healthcare costs to go up.
One of the other things I want to talk about is that last bullet point. Some of y'all might be fully insured today, and so this directly applies to you. If you are self-funded and you're using one of the major carriers as the administrator and you're using that, leasing that network, you're using what they've negotiated on your self-funded plan. So you've essentially given them a blank checkbook. There's no risk management going on.
It's the same engine that manages the fully insured business as the one that's managing the ASO business by and large. Again, there's some nuance to that. There's some, in the weeds discussions, but at a high level, that's how this works. So effectively taking this into account, carriers are no longer in the risk management business. This is why you see things like we have here on the screen. The problem with your health insurance cost is the cost of your health care. And so this is a hospital facility in Dallas, Texas, that's posted their price transparency file. And we see for CPT code 33206, which is a pacemaker install, that their billed charges are $14,958. Their cash price is $5,900. So Blue Cross and United are paying $30,000 and $43,000 for that CPT code when the billed charges are only $14,958. So if you know enough about healthcare, you could have some questions offshoot of that, related to DRGs and other things. But for the simple purposes of this is the kind of murkiness and lack of transparency that has caused their stock price to go up and your deductibles to go up. So at a high level, we wanted to focus on that. And then can you click on that other picture? Because I think these are kind of fun and interesting. No. The on the main slide.
Yeah, that's a great one.
So these are actual claims that have come through. A cranial support system for $450. We colloquially call that a pillow. $450 pillow. Acetaminophen tablets, a Tylenol, $513. An oral cleansing device. Some of you may call it a toothbrush, for $1,000, $1,050 specifically. And the old mucus recovery system, the box of tissues, for $75. So these are real claims that we've seen in hospital files.
It's the softest tissues you've ever purchased.
They are very, very nice. So where's the arbitrage? You might see all these prices and say, well, how do you go about it? Again, it's finding the opportunities here. So the average national price for a lumbar laminectomy, $77,000. We're able to procure that through higher quality physicians for $10,190 on average. Same thing, total knee replacement, you've got $40,000. We actually had one in Thrive's plan that was almost $98,000 for a total knee. We get that actually here in this market for about $19,000. But you can see these examples here going all the way down to MRIs and CT scans. There's just arbitrage and there's savings opportunity everywhere because the markets are so convoluted. So we just wanted to show you these examples.
Just like every other purchase, it's when you go get an MRI done, have a surgery, they don't tell you the price up front. What happens is 30, 60, 90 days later, you get a bill in the mail showing what the amount that you owe and maybe even what the bill charges were. It's unlike any other purchase we make in our lifetime. I mean, I can go spend 15 minutes in the mustard aisle at the grocery store and look at every different type of mustard that they have and put a value to cost analysis for me on there. We don't have that in healthcare, and that's a problem.
So in going back to the MLR rule, if 85% of our cost on a health plan is claims, then why are we as a broker community, as employers, making decisions every year based on administrative costs when we know that that's only 15% of the equation? If we're not impacting the cost of the 85%, then we're never going to see meaningful reduction, right? So that's where we spend our time and energy, and that's what we want to show you today. Okay, so if you've ever been glazed over by people like me talking to you about underwriting, hopefully this is an informative discussion. So premiums, go ahead and pull up the first image. Premiums in the health insurance world, there's this idea that, fully insured, we say it's the greatest marketing term that was ever invented because you're not insured. You're deferring the cost to next year based on what happens this year. So we have this graphic to show you that year one conveys to year two. That's the prices you pay. You pay for year two's care and year three and so forth and so on, with a few minor adjustments that we'll show you here. But I want to break down this concept that you're fully insured against major risk. You just carry it in a different way.
What we wanted to do is we wanted to walk through an example with you on this and how this works.
And I mean, just the point of that, I mean, it's one thing for the employer to look at that as well, because for those in HR, you're kind of familiar with, okay, this is what we thought we were going to end up spending this year. This is how the premiums broke down. This is what the corporate office is going to absorb. This is what the individual employee is going to absorb. But I think if you really can translate that message down to the consumer themselves, the employee themselves, when employees realize just how much their personal use of the health plan impacts what they will pay next year and what their cubicle mate and their team member is going to pay, it really changes how people approach healthcare, because once you equip them with the things to ask, the things to say, some action plans that they can take, all of a sudden they realize, wow, okay, I am in the driver's seat of this. And if I want to pay less next year, I need to make sure I'm being wise in how I'm consuming this plan. And that was probably one of the more radical things that I learned from working with you guys, which is just, you're not a victim. You're not along for the ride. If you're willing to stop and ask these questions, if you're willing to stop healthcare providers and ask these questions, all of a sudden you get different outcomes.
Yeah. And when you understand the incentives that are completely, the tentacles of the incentives that are throughout the industry, it starts to make sense that these doctors they're not bad people. They're doing exactly what their job requires of them. So going into just kind of a nerdy example, we want to show you that your loss ratio is maybe not what you're told all the time. And so we're going to use some round numbers here of $1 million of paid premium with $900,000 of paid claims. So in a traditional, without looking any further, in a traditional setting, a broker comes to you and says, your loss ratio is 90%. Their target loss ratio is 85%. We're going to factor 8 to 11 points of trend, depending on what's going on. We're going to add that to the 5% that they lost. We're probably going to see you get an increase in the 13 to 18% range, which means they're going to come out at 25 to 30% in hopes that they come out below that. You've probably seen this song and dance a million times if you've gone through this exercise. Well, what we want to show you is that 90% loss ratio might not be what it was, conveyed to be. So in this example, we have $400,000 of prescription drug claims, and we have 2 large claimants at $100,000 apiece. We have a pooling point of $75,000, which if you've ever worked in a self-funded plan, that's what we call our specific deductible. In a fully insured plan, they call it a pooling point. It's effectively the same thing. They are reinsuring large risk to another entity, they being your insurance company. So they're not actually carrying the risk over $75,000, and neither are you as an employer. I hope that makes a little bit of sense. So the first thing we do is we calculate what's called your pooled claims. So we take your 2 large claimants, if you recall, at $100,000 a piece, and we cap those at 75 because that's the retained risk. So now we've pooled off $50,000 of claims that your insurance company had reinsured. So those can be removed from your aggregate, your gross loss ratio. The next thing we're going to factor in, because it's the second biggest bucket, or sometimes the largest bucket, is your estimated pharmacy rebate revenue. And so we use a very conservative walking around number of 30% of the pharmacy revenue generated by your case, or in other words, your RX claims. 30% of that is going back to the insurance company in the form of a rebate when you're fully insured. So if you might have heard and had your mind blown a couple of years ago when CVS bought Aetna. How does a pharmacy buy a large insurance carrier? Well, there's a lot of money hiding in this bucket, and Optum and United Healthcare are the same company, more or less. They're sister companies. And so these 2 buckets are intertwined, and there's revenue shifting back and forth. So say that to say there's another $120,000 adjustment just in pharmacy rebate revenue that we add to the 50,000 in pooled claims. And all of a sudden we removed 170,000 from the paid losses of your insurance company, because those aren't losses, right? They're getting reimbursed for that money, but they reflect your 90% loss ratio when in fact they only lost 73% of that. So I hope that makes a little bit of sense. If now I'm going to negotiate your renewal with a 70% adjusted loss ratio, I'm asking for a rate pass, not a 13, not a 15. I'm asking for a rate pass, because at 73% with an 8% trend, that gets them to 81%, which is well within their range of profitability that they're looking to get at. Hope
Yeah.
that helps.
And I will say, of all the years that we were on just normal, what I'll call fully insured plans with United or Humana or Blue Cross or any of those, you never get that kind of explanation because, of course, it's either not explained to the broker that can work with them, or they're kind of aware of what's going on, but there's no control because all these people are working together behind the scenes. There's a reason why there's not transparency to a lot of this. And I think at pharmacy specifically, and I think we may get into those numbers for Thrive here, but pharmacy specifically for me was just such a infuriating point when we realized how much was being spent at some of these games that were being played with the rebates, and the fact that a lot of our employees could get free medicine or extremely cheap medicine, which is awesome. I mean, I want to make sure that people get that, but the pharmacies are accomplishing that by basically not requiring any out of pocket from the employee who would reasonably create a stir because of what they have to pay for the drug, only to hit it on the plan itself, of which they will pay that in the future. And so those things were just absolutely infuriating to me.
So a fun little exercise for you guys to do. This actually happened to me not too long ago. I was on a major commercial plan with my prior employer, and I had a prescription to go fill for my daughter. And it was a standard antibiotic, kind of deal. And they said, that's going to be $33. And I said, well, what's the cash price? And they said, oh, well, the cash price was like $2.85 or something to that effect. So I said, wait a second. So now I'm paying an extra 1,000%, basically, an extra $30 on a $3 prescription just for the benefit of using my ID card and having it accumulate toward my deductible. And so those examples exist everywhere. It's not the rule. I mean, it's not every single prescription you fill, but I would encourage you to ask that question, and it'll be very enlightening why you're paying 10 or 11 times the cost of the prescription. So
you can even do that on a medical procedure. We had a member that went in for a CT scan, and they asked them for $3,000 up front for the CT scan. And they said, well, what's the cash price? And it was $500.
Yeah. So when we see an employee asking those questions, our job becomes, how do we incentivize those behaviors to make sure we're getting the lowest unit cost within a specific provider, not compromising quality, not asking them to go get it done in a dungeon. It's just by asking one question, you cut the cost by 80%. Where else does that happen besides healthcare? Okay, so there's your underwriting. I'm sorry we did that to you guys. I know that probably sent some of you to screensaver, but hopefully it was helpful in a way. The other element to what we do is we want to help you make this as simple as possible by focusing your efforts on what really matters. And the first piece of that, and the underlying, bedrock to all of it, is the employee experience. Your employees have to appreciate this plan. They have to enjoy using the plan when they have to, go and get healthcare. It can't be a total beating. So that is always in the background of everything we do. The second is curating and crafting incentive structures that reward decreasing the cost of care and not increasing the cost of care. So putting in the right incentive structure. And then finally, program design. And that's using, various, program designs we'll go into here in just a moment to make sure that we accomplish those goals. Y'all have anything on that? Great. Okay. So, we've got the quote here: good questions inform, great questions transform. And so there's 4 questions I think you should all write down. And you should start asking if you're managing a benefit plan. These need to be 4 questions you ask every year.
And these are the questions that Thrive kind of had asked themselves as we were going through the first iteration of building this new way of how they offer healthcare.
Yeah. So the first question is, how are we establishing solid risk fundamentals? What this means is getting the right people on your health plan. So you have to get a good insurance 101 is spreading risk across a large number of people. Well, if premiums are at a point where your healthiest employees forego coverage, now you have sick people on your plan. And over time, that gets worse and worse. You have a plan that runs poorly, you get an increase. Those moderately healthy people continue to drop off over time, and you're left in what we call the death spiral. So this means establishing the right eligibility definition for your company, maybe impacting your hiring practices in a certain way and how you structure those things. And then finally, what you contribute to premiums. So establishing solid risk fundamentals, everything else is moot if you don't do this part well. Number 2, what are we doing to actively manage risk? So healthcare, it's a matter of when and not if you have high cost claimants on your plan. You can't impact when somebody gets dialysis. You can't impact when you hire somebody that has hemophilia or has cancer or has any of these various high cost conditions. What you can do, though, is when those things happen, make sure that you're providing the highest possible value, meaning lowest price for the highest quality that you can. And this is the area where insurance companies are not doing anything because they're not incentivized to do so.
Yeah, I would say a major red flag for anybody that's managing healthcare is if you're not getting good reporting on a monthly basis as to what's going on in your health plan, then you're being taken for a ride, because you can't manage what you can't monitor, right? And you also can't expect anything that you can't inspect. And so a lot of those terms get used around the TMC group, but it's so true. And so to me, that's a major red flag. And that was a major issue I had under our previous plan, is I kept asking for these reports. Oh, okay, well, here's 3 months ago data. Well, I mean, I don't even know if we're having the same issues 3 months later. We were dealing with a rash of people going to the emergency room for headaches back in 2018 and 2019. And those were all things that could be influenced and incentivized just by saying, hey, we're seeing this rash. Let's immediately get some information out there and equip people to take a different action. And all of a sudden, we started to see those numbers go down and the plan utilization go down and be used the way it was supposed to be used, not going to the emergency room for headaches. And so, again, every situation is unique, but that was a trend that we saw where that was not an appropriate use of the plan. And so, again, major red flag, if you're not getting good, detailed reporting on a monthly basis, major red flag.
Yeah. So let me ask you this, Rich. You worked for a carrier for a number of years. How did you use information asymmetry to get better pricing for the insurance company at the expense of the client?
So if a group had their claims looked phenomenal, let's say they had a 50% loss ratio based on what they paid in premium versus what went out in claims, we would always say they're not big enough, they're not credible. So, or there's emerging risk was another favorite term that we used to like to use within the broker community. And it was an easy way to say, hey, we can justify this even 8%, 5% increase, just increasing the pie a little bit more by saying, hey, the group's not big enough, so one large claimant is going to blow this thing out of the water. They're 50% today, will be 200% tomorrow. Or, hey, there's a couple of drugs on this plan that are going to hit here soon. You can't see them yet because the data is so lagged that it would justify that increase. And if you don't have the insight to it on a weekly basis or daily basis, you can't make those decisions. And one of the things I do want to say, though, is you don't have to do this like the HR person, the CFO. This isn't more work on your plate to actively manage the risk. You have to build the program correctly. And that's kind of what we've become experts in. And we put those components into on a daily basis, go in and manage the risk, not add something additional to your plate, because who wants to be in the healthcare business?
Yeah, no, that's a good point. Absolutely.
The other thing on actively managing risk real quick is this is going to be really important as we move past COVID, because two things. If you've watched any NFL game this year, there's a commercial talking about how cancer diagnoses are down some 50 to 90%, depending on which diagnosis of cancer it is. It's going to be really important to manage those expecting costs because there's later stage diagnosis. And we know that that comes with a higher cost, obviously, to both the person and the employer. And then the other thing is kind of jumping out of my head.
While you think of that, we got a question that I'm going to run into from Frank. A small employer plan with less than 100 employees limits what information you can see as an employer, true or false. So in a traditional carrier insurer built model, so a model built by the insurance companies, yes, they hold an asymmetric information advantage. This is why one of our biases is toward an independent third-party administrator that gives you access to claims data up to the minute. Not up to the minute necessarily, but up to the day. And so those refresh every single day and you can see what's happening actively in your plan. So yes, if they control the flow of information, not necessarily if you control the flow of information. And that can also depend on state. That can depend on what type of program that you have.
That's right.
All right. So the third question that we ask is, what are we doing as a company or a health plan to create smart consumers? Rich mentioned this a moment ago. We don't think we give people enough credit. We're some of the best. Americans are some of the best shoppers on planet Earth. Rich was trying to buy Texas OU tickets, hook 'em horns, this week, and went through every app and platform to find price and value that made his game day experience worth the financial investment to him. We will do this for just about anything in this country except healthcare, because it's not always made easy for us. And so that's the next question. As a company, what tools, what resources, what ongoing education are we giving people to help them make decisions? Because what we find is when your employees know better, believe it or not, they do better. Not everybody is as selfish as sometimes we give them credit for. Michael, what have you seen on this?
Yeah, I mean, to that point, sometimes I've felt this myself when you're sitting in the doctor's office, even if it's a primary care physician you've seen a few times, and because they're an expert and they're in an authoritative type position, sometimes that natural human inclination is, ooh, I don't want to push back on this, or somebody is telling me something that I don't know if that's right, so I'm not going to say anything at all. And so part of what is so important to transform healthcare in this country is when your employees are informed to their rights, to expectations, to what's true and what's false, all of a sudden, that's how they can become a smarter consumer. It reminds me of a lot of those studies that came out in the 50s and 60s where they did, authoritative type experiments in colleges across America. And that's so true whenever it gets into these types of situations. Folks don't know all of the moving pieces in insurance and healthcare. And whenever you have an authority, a really smart doctor that's telling you something, or some sort of an administration that is supported by a doctor, the human instinct is just to comply and not push back very hard. And so that's what being informed consumers can do, is it can allow you to respectfully push back, or if nothing else, just pause. No, I don't need to buy this right now. Let me pause and let me make sure this is what's best.
So one story I've got on here, and it's just because it's fresh in my mind. It happened this past Friday. It was actually a member within Thrive's population. We have, as part of our firm, we have a nurse navigation component. We have a nurse with 25 years of nursing experience, a great deal of clinical knowledge on our team that helps guide members toward high value care. And we had a member that reached out and said, hey, I need to get facilitated with this nasal surgery. It was a sinus surgery that was going to be about $40,000. And she was very worried about the surgery, not necessarily the price, but she was worried about the surgery itself. And so she connected with our nurse. Our nurse got her referred to one of the top ENTs in the state of Texas. She went in for that consultation. The physician said, you don't need this surgery based on this, this, and this. I'm going to order a CT scan, which we got down the street very inexpensively. He ordered the CT scan, and she came back and said, hey, great news. I actually don't need the surgery. I'm very comfortable with the new diagnosis. And by the way, that's $40,000 that's taken out of the health plan budget, that's reflected in lower premiums in years going forward. So it's a positive outcome all the way around. So how are we creating smart consumers? That's one thing. I think we have maybe a couple slides to touch on that here in just a moment. And then finally, how do we measure performance? So one of the things that's always surprised me, I guess, Michael, before we started working together and reframing how you thought about this, how would you measure performance for your health plan?
Usually would happen twice a year, maybe. And, we'd get some sort of a mid-year update, and it was always trending poorly for the most part. I mean, it always is, right? Because you don't know what's going on in the plan, and just all kinds of things happen. And then at the end of the year, come October, about this time, I'd start to get a knot in my stomach, because I knew what was coming around the corner. It was going to be a premium increase that, as an employer, as a top manager at the company, I was going to have to decide how much of this can the company absorb while still offering good interest rates to our borrowers, while still offering great customer service to our branches, versus how much can the employees absorb who are really driving the usage of the plan, but without pricing them out, without causing them to say, hey, I'm sorry, I can't even afford the benefits here. And so I'm either going to have to come off the plan, which is a bad result if it's a healthy individual, a healthy family, because you need their positive performance to help even out some of the other bumps in the road. Or they may even get incentivized from another employer that says, hey, guess what? There's a lot less cost over here. We effectively just gave you a pay raise, come on over. And that puts the employee in a tough spot. So, I mean, that's how things would look for us, is about twice a year, we'd get some sort of check-in as to how things were going. And then you get a very short period of time to either accept a rate increase or have to flip to another plan for either less of an increase or potentially a rate pass, only knowing you're kicking the can down the road for the next year or two whenever you do get hit with those.
So what do you monitor now?
Oh, lots of stuff. So, as we talked about, I get weekly reports that just shows us how our spend is going. And so, for anybody that's in HR or maybe top management that's on the call or will watch later, everything is HIPAA compliant. So I'm not seeing anything that's tied to any one person. All I can see is dollars, and I can see some high level things. And so really some of the best things I ask the team is just, oh, hey, we spent a lot of dollars here, but what does that mean? You know, is that something we could control? Has this been properly repriced yet? What is the status of this? And it allows me to have a really good pulse on how we're performing throughout the year, so that I can either get more proactive with the team and say, hey, we're seeing a lot of dollars flow into this area. Let's create some more education around this. Let's create some more advocacy around this. We've got the nurse advocate on Cairn that can make outbound calls if we see something that needs to be addressed. And so that's really exciting. And then the other thing is we can begin to prepare for the future. Hey, we're saving enough dollars here that why don't we increase our employee benefits? We've brought on MFMs, the maternal fetal medicine, which creates great outcomes for employees on the plan. And it also has the potential to reduce the premiums overall, because if we get proper healthcare and proper medicine for babies and mothers during the pregnancy, then everybody has a better outcome. And so it's just exciting whenever you can actually get access to the data.
So you touched on two things, really these second and third questions. The second one being, what are we doing to actively manage risk? That maternal fetal medicine program is one of them. When a mother at Thrive Mortgage finds out that she's expecting or is trying to get pregnant or family planning, she can consult with a maternal fetal medicine doctor at absolutely zero cost out of pocket. Why? Because having poor advice and guidance from someone who's not trained in high-risk pregnancy can be a very costly path, to go down as an employee. So benefits the company, but by the way, that mother has also got the peace of mind of knowing she's got an experienced MFM at her disposal at any time. So very, very cool program that fits into both of those buckets of both education with better outcomes and risk mitigation. The next one obviously is how do we measure performance for the plan, our consumers or our members? So one thing that we look at, we just reviewed a report last week. We've had 20 MRIs and CT scans this year that have what we call blown through the stop sign, but they've opted to pay out of pocket, use their deductible, use their plan versus the options that we offer for free. And so our job becomes, was that a gap in education? Was that a gap in accessibility? Was it going to require them to drive 15 minutes when this one was, 5 minutes down the road from their house? Those are the questions that we can look into, but we've got of the 100 plus, imaging, complex imaging procedures that we've had this year, only 20 of them have not been captured by that. So again, it's just another metric that we track. How are we doing? How can we improve that? And then finally, we have on here, how are you evaluating performance for your advisor or for your broker? And for us, that boils down into what are you spending now versus what you were spending before? And what are you spending now versus a risk adjusted version of that, given, hey, we hired somebody that had a child with leukemia and that cost us X amount. Those have to be taken into account, but you have to know what your baseline is to be able to monitor and improve that.
And your baseline can change if you've changed your plans, if you've changed carriers. A lot of times what we've seen is cost containment measures have been switching carriers every 2 to 3 years to kind of bring that baseline down. And then, it'll go up eventually. It's like the new business discount. And if you raise deductibles and out of pockets, co-pays, and just cost shift back to the member, that resets that baseline as well, because the member's paying more before the plan or the carrier were to kick in.
So I think
one thing I wanted to bring up here, when Thrive asks these questions of themselves, this is how they've trended since 2019. They had $1 million worth of pharmacy spend. In the entire 2019 plan year, they had 199 averaged enrolled. They were on UHC. Optum was their pharmacy benefit manager. That equaled to about $418 per employee per month. This year, through the data we have, we are trending at about $67 per employee per month with about 394 enrolled. This isn't telling folks you can't go get a medication. You've got to go get a generic or anything. We educate people. It's just finding different ways to source them. And one of those ways is we've got different partners. So if you look at a couple of these medications right off the top, Januvia, Xarelto, Jardiance, these medications you see commercials for them every single day. We can get these same name brand drugs for 76% savings, 66%, 78% savings On Thrive, they had 131 medications flow through this program. The total cost was almost $59,000. 8,700 of that was for the members. We can actually procure all of these same medications for just under $15,000, and nothing is paid by the members. So the employees effectively get a raise, get their same medications that they need, and everybody wins.
Yeah, just so much to unpack there. So, looking at this alone, some of the coolest outcomes, and I know Lauren with our HR team is on here, are the stories that she gets to hear of, oh my gosh, I was paying X amount of dollars for this prescription and now I get it for free. And that's a huge deal, especially as we look at just inflation rampant all throughout the economy and other things. When you're talking about putting more dollars in somebody's pocket, allowing them to keep more of that take-home pay and not spend it on things like medication, that's such a huge win. And that's true of surgeries. But for us, again, the low hanging fruit oftentimes are these medications because they're recurring. Again, you've been prescribed it from a doctor. And so the implication is just, hey, this is what I've been prescribed. This is what I need to take. Or going and getting it filled at certain high cost pharmacies when there's another way to fill it. And it could be mailed to you directly without ever having to leave your home. There's just so many options whenever you start to break apart these different components of the healthcare system and really the insurance system and how they interact with each other.
Yeah, and there's another element to this, which is the satisfaction of the patient. And one of my favorite stories that we've had with Thrive is we had a dependent who needed a double hip replacement, and she really wanted to do them at the same time. And so the hospital would not allow that, not because it was necessarily risky to the patient. They used that and said, oh, you don't want to recover from two hips at the same time, but because now they get to charge the facility fees twice. And so they were going to be two separate $70,000 hip replacements. When the member wanted to only recover once, she did not want to do this twice. And so we went to our surgical partners who evaluated the situation, evaluated the case files, and said, this can absolutely be done at one time. And they did the entire surgery at $41,000. And so you look at that single procedure, that single option, better outcome for the member. They were thrilled. They only had to do this whole thing one time. And the plan saved about $100,000, which at the time, we were sitting around a couple hundred members. That was, a significant amount of premium dollars. That was like a, $500 raise for every employee in the company. So just a really cool success story, with something like that. So do you have the case study?
No, I don't have the case study up. I can pull it if you'd like.
Yeah, go ahead and pull that up while we've got a moment.
Yep. So the Thrive case study.
So we just want to be, and if you can zoom out just here, so it's all, there we go. Since Thrive started this program, obviously we're coming up on 24 months here shortly. Their total claim spend has dropped from 10,817 per employee per year down to 5,970. So 44.81% drop in cost. But as Michael mentioned, the thing that they were most frustrated by were the gains in the pharmaceutical side of the business, which is not surprising to Rich and I. We see this all the time. And $5,102 per employee per year in pharmacy spend has now been cut to $806.37. And the upshot of that is that most members, or not most, but a lot of members are not paying at all for drugs. Those are being sent to them at no cost. So just figure that was a good way to, kind of summarize, does this stuff work? Yeah, Rich and I say all the time, we're not that smart. This is just kind of common sense. If you have two objects that are of similar or sometimes even much greater quality, and one is much lower priced than the other one, then how can you facilitate a smooth transaction for the lower priced, high quality item? And so that's what we do.
Yeah, and one comment I would make. So thankfully, most TMC members saw a great 2020, probably a pretty good 2021. But a lot of folks are probably on your plan now that weren't before. And so if you came into 2020 feeling like you had a pretty good handle on just, okay, here's what my renewals have been, this is just sort of a status quo, because we've hit some level of equilibrium. Now, all of a sudden you have dozens, if not maybe hundreds of more employees on the plan. And so you have no idea how that plan is going to perform. You just don't. Neither does the insurance company. And so, even though I think some people got a little bit of a pass with COVID just because nobody could legitimize increase in premiums when nobody was going to the hospitals and nobody was really using the plan, I think some people dodged some bullets in 2021. But as 2022 and beyond rolls around, and we know we've got inflation, we know we have healthcare systems that are having to make up just the bad year that they had in 2020 because nobody was going to get service or have surgeries done, elective surgeries, that kind of thing. I fully expect and know that we're going to see these premiums go up. And the fact that you don't know necessarily how your plan is going to perform, it's just ripe for a lot of these insurance companies to say, you've got a lot of new covered lives on here, a lot of states, a lot of other things that you're not familiar with. And so it's going to make it that much harder for you to differentiate. Is the premium increase I'm seeing, is it legitimate because of what my claims have been? Or is this just an opportunity, that asymmetric information that you guys talked about, is that just an opportunity for them to make a money grab and I'm stuck holding the bag?
Yeah, that's a great point. So the thing that I would leave you guys with is, one, you're not powerless. You can start somewhere and you can start to make a change. No matter where you are, there is an opportunity to improve today for whatever you're doing. And that can sometimes just be education. Other times it could be doing what Thrive's done, where they actually change the way that they purchase healthcare. But you have more power than you think. And that's a big part of the mission of what we're doing. Whether we're ever engaged with you as a client or not, that is completely immaterial. Thrive, Roy Jones, Michael Jones have a passion to see this problem fixed at scale across the country and see employers start to take control back from these folks who have had a fun run of stock performance and of company performance over the last 10 years. And so if we can ever be a resource for you in that regard, please let us know. Sarah, did you have any questions for us?
Awesome. Yeah. Thank you so much, guys. I do have a couple of questions for you guys. And just a reminder to everyone on the call, please feel free to drop those into the chat or the Q&A boxes. First one I have, does any of this create more work for HR or the executive team?
Yeah, great question. And, our HR person, I believe, is on the call as well. So one of the things that Thrive did was a little bit unique is, as Taylor mentioned, Roy and I just got super passionate about this. Taylor planted the seed in my mind. It took about 6 to 12 months for me to really take it seriously. But as I read books, as I asked questions, as I encountered some of the problems we had, I just thought, okay, yeah, we've got to make a change about this. So we went on the deep end and just super educated ourselves, learned about these ecosystems. But I would say for your normal CEO, CFO, HR representative, this moving to this type of a plan will not change your day-to-day very much, and it does not require you to become an expert in the healthcare industry, and it does not require you to add hours and hours to your day or week trying to manage this, or have to add staff to manage this. That's one of the reasons why you would talk to a Cairn, because they know the tips and tricks, and they've put together the ecosystem so that your plan can perform as you design it. And that's what I think is so cool, is you can design the plan around what you need individually as a lender. And so you may say, hey, we want these services, or we want the plan to perform this way, or we want our employees to have to go down these routes in order to have a certain level of service done. Whatever the case is, you get to be in control of it. But once you design it, really, it's up to you to monitor it. And of course, Rich and Taylor are always monitoring things, pushing information, making sure the providers are doing what they're supposed to do. But once it gets spun up, it's really just managing it. And it's no different than you looking at your business intelligence reports. It's no different than you sitting down and looking at your monthly P&L. If you're willing to just dedicate a couple of hours a month to monitoring these things, asking good questions, and trying to make sure that you at least have a say in the outcomes so that you can continue to see price decreases, you don't have to become an expert, and it does not have to become a full-time job.
You touched on something there, Michael. What's behind the name Cairn Advisors?
Yeah, good question. So for anybody that is an outdoors person or likes to hike or anything like that, or even if you don't and you've just been out on a trail once, you've probably seen a stack of rocks, right? So those stack of rocks are meant to be beacons that you're on the path. And typically it's whenever you've gone off of the National Park Service steps and, things are properly cleared. When you go off a little bit into the unknown, a little bit into the wilderness that we'll call non-fully insured BUCA plans, you need a guide. You need some sort of map or some sort of path to follow that are marked by, say, Cairns, wise advisors that have gone before you and left these beacons for you to follow so that you get to the destination, so that you can get to the top of the mountain, which would be lower health insurance premiums and better health outcomes for your employees. And so that's where the name came from. And it's so true because as we looked to do this, kind of initially, and you guys had experience with this, but it's different whenever whenever you're coming off of a fully insured plan, looking at something like this, you truly need to have trusted advisors that know what they're doing. And one of the things that is unique about this joint offering that we have is that we've done this for a mortgage company. So it's not some insurance broker that doesn't understand what it's like to talk to a loan officer or try to recruit an underwriter or retain a closer or whatever the case may be. We can hand you the game plan and say, look, this is what has worked well for us. Here's what you should avoid because this didn't work well for us. And so you get to learn and decrease that learning curve so that you can have a much more impactful and quick rollout and actually start hitting your objectives, which should be lower costs as well as increased care for your employees.
I will say I've been asked, dozens of times why I left. I was working for a large national agency and why I would leave my clients to come and do this. And simply put, what Michael just described to me was so powerful. I've managed many self-funded health plans, as has Rich, built and sold them. And we haven't seen anyone doing it quite like Thrive was doing it from a standpoint of really focusing on the member and understanding their niche so well. So that it was a cool thing for us. Sarah, did you have any other questions?
Got one more here. How do these plans protect the company from extremely large claims?
Yeah, that's a great question. So what we do is we build in a specific, a stop loss amount is what we help your organization purchase. And it's going to be a different amount for every size company and what your appetite for risk is. And what that essentially does is any dollar amount of, or any claim amount of above that dollar is going to be retained by the stop loss insurance carrier. It's very similar if we go back to the underwriting in 3 minutes. This pooling point, this is what the carrier set for you in your fully insured plan today. So anything above that 75,000, let's say, is not going to be on your balance sheet.
Yeah, in another way, I might explain that just, mortgage company boots on the ground, like this is what I got to deal with every day or every month, or as I'm projecting out for the year, what does this look like? Every year heading into your plan year, you're going to have a maximum out-of-pocket dollar figure. So I know that even if all hell broke loose and we had a catastrophe in the plan, this is my maximum dollar exposure. So it's not just a free fall if things go poorly because of a rash of cancers, of some unfortunate diagnosis, anything like that. So that gives me some comfort because that is very much what we're getting from, say, a fully insured plan. Now, granted, the fully insured plan is going to try to cap that at some level because they know they can get it from you next year. And so at least you know what your maximum is going to be. But the way it'll work is you may have an individual claimant that has $100,000 worth of cap. And so you cannot exceed over $100,000 for that individual without being reimbursed by this insurance policy. And then you have an aggregate amount as well. And so that's how we as a mortgage company got comfortable with that at 194 lives, because I'd heard from years, oh, it's dangerous. You never know how much you could be out of pocket. Like you could just, you could go broke having to fund one of these things. And it's simply not true. It's a scare tactic. And it's also folks that just, they aren't well versed in how these things work. So you do have insurance that's protecting you. It's partially self-insured is what we have seen and participated in, and it's worked really well, and to be clear, you guys saw the numbers and you may think like, well, that's staggering. We couldn't have similar results, but we have had some unfortunate situations on the plan. You just do. Everybody will. And so we achieved these numbers in spite of having some high costs and high cost claimants on here. So it's 100% possible. And we are just actively making sure that people are well informed and that they are using all the tools at their disposal, because it doesn't help to build the ecosystem and have all the tools if people don't know how to use them and don't know how to access them.
Yeah, this just gives you the opportunity to manage those claims. And that's the thing you're in right now. You can't control when they happen, or even if they happen. You can definitely control what you do when they do. And that's what Thrive's been so effective at doing. All right.
Awesome.
Well, I think that's all we had, Sarah. We'll let you kind of put a bow on it.
Great. Thanks, guys, so much. I just want to thank everyone for joining the call today. And thank you to Taylor, Rich, and Michael for the great discussion today. You guys can find the podcast and the YouTube links to view this recording on demand in your inbox tomorrow. So thanks, everyone, and enjoy the rest of your day.
Thank you.
Thank you.